Good afternoon. Hi, everyone. I'm Dr. Guo in Taiwan. I'm the radiologist of Chime Hospital in Tainan, Taiwan. On behalf of Taiwan Radiological Society, we are very happy to have Dr. Charbel Sadde from Lebanon. The professor Sadde is the professor and chair of Faculty of Health Science Medical Imaging Science program in American University of Beirut, which is located in Beirut, Lebanon. He is the program coordinator and also adjunct professor of medical imaging science in the University of Canberra, Australia. Professor Sadde also are educated in Australia and now working in the American University of Beirut and also its medical center. So today we are very happy to have this meeting and webinar. The webinar is kindly sponsored by Elsevier, a publishing company which is very well known to everyone. And we are talking about the hepatocellular carcinoma, about the imaging diagnosis. So let's welcome Professor Charbel Sadde.
Thank you very much, Dr. Q. Can you all hear me very well? Can you all hear me?
Yes, yes.
Fantastic. Excellent. So first of all, good afternoon to everybody in beautiful Taiwan and within the region. I'd like to thank you all for allowing me to present my work today, and more importantly, for being able to share the insight into what we're having. So I will keep it very clear. We'll go through some slides first. And what is important to remember as radiologists, we have such a large role to play in medical imaging. And the thing is now is that with the ever-changing landscape of medicine, technological advances, but more importantly, the COVID-19, this really pushed us into a corner when there was no evidence available for people. We didn't have rapid access to literature because it took 3 months to actually get out for fast publishing. And so this became tough, especially in the Asia Pacific where it was first hit. So I'm just going to go through and just show you about what StatDX has done for me and my role. So I've worked in big university hospitals around the world over the last 20 years. And every time that I've progressed from one institution to the next, I've always had StatDX, because from the recent data and literature, it reduces diagnostic errors by 19%. Secondly, for the new radiology residents or registrars that are in training, as well as the radiologists who are not subspecialized in neuroradiology or breast or whatever, it reduced the error rates by 24%. And more importantly, when you have those complex cases, especially when you get those very rare pediatric or cardiac anomaly patients that you don't normally see, it also reduced error by 37%, and it increased definitely confidence for the radiologist by 10%. So this is probably the most important slide I will share with you as my colleagues around the world. Not everything online is true, even Google Radiopedia. I have the big radiology website called mdct.com.au. Even there, I'm very limited in what I'm publishing, because if it is not peer reviewed by our colleagues who are world experts in their chosen fields, how do we know this information is true? So you have Wikipedia, Medscape, Radiopedia, whilst they are a dedicated industry with experts, but they're not critically reviewed through a peer review process. Radiology is also one of the most technologically orientated specialties. It is caught up in a complex and interesting swirl of diverse trends. Artificial intelligence in the world is based on radiology images as the first step. Second of all, the changes in government payments for a CT scan or MRI is reducing. There are new policies surrounding clinical practice and medical tech information. Also, there is collaborative approach in medicine now. Radiologists, we used to sit on our own in a corner in a room, make the diagnosis and give an opinion on an image. Now it's multidisciplinary, and now we're actively involved. And especially today when we talk about HCC. Now, when we talk about HCC liver tumor imaging, the world experts coming out of Taiwan, where you look at the BC, LC, stage A, you guys are the best at transection or, segmenting lesions out of the liver versus other updated guidelines such as the ESMO 2020 guidelines, where they looked at now using CTACE or Lipodol with doxorubicin. And the move towards collaborative radiology and collaborative medicine, patient-centric care, we're looking at outcomes more than we ever were before. And from an IT perspective, we're now looking at interoperability as the driver of care. And looking at standards and standardization of interfaces is now the new care model. More importantly, now we're starting to look at standardization of radiology reports. Before, we used to give 1 lines for a chest x-ray. Now there is a standard, depending on which standard you want to follow. And creating standardization in your practices has also become another challenge. And this is the biggest problem we're facing now. Workload has increased for radiologists. Subspecialty reporting now is bigger than ever before. The general radiologist is still very important, but now the subspecialty radiologist needs that extra edge. And with COVID, no more traveling. We're now going on to webinars, but even then on webinars, we don't have enough time to go through the information quietly as we want to. And the biggest problem now is there's more than 100,000 radiology journal articles published per year. So this will take us about 5 years to read just for reading all the papers that came out in 2020. So now we're overloaded with information, which is even more. So now, how do we keep up? Conferences we can't attend. It's now become expensive and institutions are cutting back costs. And more importantly, even if you were to go online, you can't learn at your own pace. We're so busy. So having rapid access to high quality information for us is really important, especially for presenting and teaching. So if you're in a tertiary institution versus a private clinic, remember you still have information that is being continuously updated. And the new normal post-COVID environment will require radiologists to stay ahead in teaching, reporting, and providing opinion on new diseases, especially on pandemic diseases. Now, this was a problem because when we looked at various different types of information, we were looking at ground glass opacities versus consolidation. At different times during COVID, you're going to have different levels of these two imaging patterns. And also, diseases have now changed the face of radiology for the future. And now there are viruses, not just the coronavirus, which is a general term, but there are many, many viruses. The world went into shutdown. We were all left alone, and people were throwing media all over the internet, which confused the hell out of everyone. However, StatDX was the forefront on this, as it was a live tool that provided support to myself, my team. So I had 140 radiologists in my team. And in this unknown environment, we had clear, peer-reviewed access to this information. And of course, you need now a diagnostic decision support tool to support us. Whilst we are experts in our chosen subspecialties, but again, these guidelines and everything keeps changing, as well as reimbursements. So radiologists need to be equipped with the various pathways of imaging, especially in subspecialty reporting. So again, really quickly, using StatDX, and I'll show you the strength of this tool, and we're going to go through some HCC cases, reduces diagnostic errors by 19%. If you're now in teaching, so for example, when I go give a lecture on, neuroradiology as a subspecialty to medical students or anywhere to any other students, or even to radiologists when I have to do a grand round, even for the entire medical institution, I just take StatDX and log in, and I just go through the top 10 cases. new radiologists, radiology residents, young radiologists who have or have not done a fellowship. Again, this helps reduce error rates and, of course, increase confidence. So now I'm going to change my screen over and we will go to the actual StatDX. So you can all see my screen. Now, if we have a look here, you can actually see quite nicely, you know, this is what you land on. So here, if I want to, I can type in the disease I want to look for, or I can go into the primary categories. But more importantly, also, I can see what I've recently reviewed in terms of which lesions. Also, I can actually see here my recently updated, what has been recently sent to the StatDX, and you can actually see the new changes and they're dated. For example, the coronavirus was on March 17th, 2020. So again, that's how fast they actually moved it out. So once it went viral within the first 3 months, already StatDX had actually sent out new updates. Also, I can track my CME. So if I need continuous medical education credits, as I'm working and I'm reviewing cases through StatDX, I can also claim these as well. So if we take a look now, we can go to gastrointestinal. I'll just click onto this. I can now go to diagnosis, differential diagnosis, or anatomy. If I go into diagnosis, okay, I can look at, for example, liver. And then I can look at, you know, is it a benign or malignant neoplasm? I'll click on malignant. And then we can go to, for example, hepatocellular carcinoma. So if we take a look here, I'm just going to show you a little bit around now. So here it shows you the imaging features. So small tumors less than 3 centimeters without vascular invasion. Also tells you the DOP, differential diagnosis, clinical issues, abbreviations. It looks at general imaging features. Is a small tumor classified less than 2 centimeters, greater than 5? And in a moment, we'll talk about LIRADs. We'll also talk about CT findings, and these are the radiological appearances. Here you have MRI findings. So on a T1 HCC, it could be hypo, iso, or hyperintense to the liver, and tumors with fat or hemorrhage are hyperintense. And more importantly, it also tells you with the gadolinium, what types of gadolinium are you using? Extracellular or hepatobiliary specific. Also, now these days we have DWI for upstaging of the modified LIRADs. When we're looking at a LIRADS 3, when you do a DWI and we see it as hyperintense, there is no restricted diffusion. That means we can upgrade it to a LIRADS 5. Also, there's ultrasound appearances, angiographic appearances, nuclear imaging, and more importantly, it gives you imaging recommendations. Which are the best imaging tools to use? And more importantly, also, if you go through the images, which we'll do in a moment, you'll actually see that it gives you differential diagnosis. Is it a regenerative or dysplastic nodule? Could it be cholangiocarcinoma? Now, interestingly, with HCC, you could have a combination of cholangiocarcinoma and HCC. Also, is there nodular regeneration hypoplasia or hypervascular metastasis? And more importantly, when we start to look at imaging features, especially in the late arterial phase, where again, the OATP markers are very low in advanced stages of HCC. So more importantly, you want to actually look at vascular flow, which goes from arterial being 30% in healthy to 70% in HCC. And of course, that's reversed for the portal vein. And then also he goes through the general pathology, cirrhosis, non-alcoholic steatohepatitis or NASH. And of course, you've got gross pathological and surgical features, clinical presentations, demographics, risk factors. So this is a complete one-stop shop for our medical information and knowledge. So this is gone through opening up the textbook, finding the right page for HCC. Sometimes they might have a lot in it, sometimes it might not, or you have to find a liver-specific textbook. You probably don't have access to the textbook. So again, you can go through all of this, and then it gives you treatment outlines. Look at this. You've got surgical resection, RF, transarterial or chemoembolization, radioembolization. transplantation, and especially in Taiwan, you guys are the world experts when looking at liver surgery, especially when you're understanding how you're having early stages of HCC where you go to resection. And then, of course, you have surveillance, a diagnostic checklist, and more importantly here, you actually have all the references. So if I was interested to see, benign findings of the LIRADS characterization, I'll click onto that and automatically it will take me to the journal article where it was written and I have access to it. So this gives us a really strong, solid foundation and evidence-based practice to what we're seeing. So now if I go back here, you can click onto this here. You can zoom it up if you want to. This is the LIRADS classification system. So now let's go through a case. What's beautiful about HCC and StatDX is that it gives you a really good insight into providing these schematic diagrams. So here you can actually see this, altered appearance, which is indicating of cirrhotic liver. You can actually see the vascular component of the lesion and how you have vascular invasion into the portal vein. So this is quite nice when you're looking at a first-time radiologist, as a learning radiologist in your first year as a resident. This is really good for learning. But also if you are to give a lecture to non-radiologists, which we do most of the time, these are beautiful images to start off with. And the great thing is here, this allows you to actually download the presentation to use. So they're encouraging you to use their information, the StatDX, in order to present it. So if I go to the next image, again, I can click on here. It shows here, this is an axial CT of the venous phase. You can actually see a nice, well circumscribed border of this lesion. There is mild internal enhancement and it's gone into the actual portal vein. Now, we also know that there's portal vein hypertension, so it's starting to cause a blockage, as well as we know there's a large hepatocellular carcinoma with mixed nodularity and enhancement, and you can actually see the tracking down through the segment 7 and 6 going into the portal vein. So it's gone into the tertiary, primary, tertiary, and secondary branches of the actual liver in these segments, and it's caused actually also thrombosis. And again, this is a cirrhotic liver. So here we can also see this is a typical T1 weighted sequence with cirrhosis or alcoholic cirrhosis, and you can actually see multiple focal masses. And this directly shows that there is invasion into the portal vein. And you can actually see the enhancement patterns as well, especially look at this here also. We can get a little bit of shunting as well. If I go to the next image, again, this is another T1 weighted sequence. You can actually see also through the portal vein, and there's also potentially extrusion or inclusion or invasion into the actual renal vein. And also here you can actually see this large metastasis sitting on the right adrenal gland. You have a well circumscribed border. Definitely this has gone through to the actual cortex and the medulla of the adrenal gland as well. And so here, this is another CT scan. This is a non-contrast. You can actually see it's a hypodense area with a nodular hyperdense or opaque relative to normal parenchyma. And then also you can see this in ultrasound. So they show you across multiple modalities how you get this. And you can actually see there is acoustic shadowing of this lesion. And of course here, this is another example of multifocal HCC. So you can see these lesions in the left lobe and into the right lobe, as well as, and this is in the arterial phase, and this is an important phase because characterization of lesions in CT and MRI, the most appropriate phase is the actual arterial phase. And then the next one is the delayed phase when you see if there's filling in or washing out. Now, also remember, when we're looking at HCC, it is really important to understand the difference in enhancement patterns between the actual hepatobiliary contrast agent and extracellular, because then you have a transitional phase because you will probably see hypodensity in the liver. It is not a representation that it's washed out. It just means that the hepatobiliary specific gadolinium cannot attach onto the OATP, which is the organic polypeptide, which is an expression, and that's why it shows that there is not much OATP in tumors of HCC. That's why we have to be careful in that. So again, here you can actually see this is the same case in the venous phase. You can actually see the IVC starting to fill up, and you can actually see areas of washout, and you can actually see portal vein thrombosis. And definitely this is tumor-based because there's areas of enhancement. And then so forth. And then again, you can look at this one here. This is a patient with no known liver disease. He has a typical mosaic pattern enhancement, a thin rim capsule, and this is a typical HCC from a non-cirrhotic liver. And this was actually a patient who had hepatitis B infection. So we can go through multiple cases. Now, also, if you wanted to, you can go through the whole series here. So you can select one patient and you can actually completely follow it through. So here, again, you can see a hypervascular lesion. You can actually see this contrast coming back in the IVC. So we're actually in the late arterial phase, which is the optimal phase. Again, you can see this. If I go here on the portal venous phase, there is a capsular enhancement that's still happening as well. And of course, this is quite important to know that this will be upgraded from a 3 to a 5 for a LIRADS. And then here, if you look at here with T1 weighted with fat saturation, heterogeneous hypervascular mass enhancement. And then on the T2 weighted sequence, there is subtle hyperintensity. It is not as bright as normal fat or fluid, but it is subtle. And then with contrast enhanced, you can also see areas where you can actually see tumor invasion into the inferior vena cava and also the right hepatic vein. So this tool really helps you understand the common variations, the tumor patterns and enhancement. And then also, if I click here onto this side with DDX, I can then also go through and say, okay, I found an echogenic liver mass on ultrasound, or I found a liver lesion containing gas. So if I click onto the liver lesion containing gas, you know, my differential diagnosis could be due to a hepatic pyogenic abscess, hepatic infarction, tumor following treatment, gas or bubble ducts. So not only do I need to know what the pathology is, if I don't know what it is, but I can describe the characterization, this will then further puts me into the differential diagnosis pathway. Also here, there are helpful clues for less common diagnosis, for example, retained bodies, or if you have an abscess, you could have Hydatid's disease, or you could also have, you know, someone who's had hepatic transplantation. You know, typical, this is a patient with an allograft malfunction and usually get this wedge-shaped collection of fluid and gas. So for example, in Taiwan, where there's a lot of liver transplantations also that occur, again, you can see this wedge-shaped appearance with gas. You would think, oh, is this abscess? But again, this could be a hepatic transplantation due to an allograft malfunction. And then and you can also go through many other processes as well. So if I go, for example, to hepatic hydatid cyst, again, you can actually show you what it looks like on a schematic diagram. It can also give you histopathology and surgical specimen images as well to show you, and radiological images as well. So this is quite interesting. So if I go back now to liver at the top here, we look at benign neoplasms with, for example, focal nodular hypoplasia. Again, this is another great, you know, schematic diagram, which actually shows you the lesion. You know, it can go through and shows you what it looks like on the CT. And more importantly, it gives you the pathology look of it as well and shows you exactly that it's wedge-shaped resection, well circumscribed with a nodular lesion and a central satellite scar, which is a typical focal nodular hypoplasia. And so again, you can go back to the differential diagnosis and you can say, okay, it's a hepatic mass in a child. Is it an isoechoic liver mass? Is it a liver lesion with a capsule or halo on MR? And then if you go back again, we can look at, you know, HCCs. You can look at, you know, biliary cyst adenomas, angiosarcomas, hepatic metastasis with lymphomas, and so forth. And then you can also click on this one, which we never went through. We can look at the different stages of T1, T2, T3, or T4. You can see if there's regional lymphadenopathy involvement. With T4, it shows you that there are multiple tumors that have gone into adjacent tissues, into the duodenum or stomach. There is vascular invasion, and this is consistent with the T4 disease. And also it shows you the routes of spread for lymphatic as well. So now, for example, it also tells you that, common causes of cirrhosis. So for HCC in Asia and Africa, hepatitis C is mostly North America, Europe, and Japan. Whereas hepatitis B is more in the Asia-Pacific region, but excluding Japan. Alcohol use, carcinogens, you have aflatoxin, which is the myocytoxin that can contaminate corn and peanuts stored in warm, humid environments. So again, with this type of carcinogen, we have this quite a lot in Asia. And also you have metabolic disorders such as hemochromatosis, Wilson's disease, or tyrosinosis, diabetes, cigarette smoking, and so forth. And also you can go more into microscopic features. So you have on histology, the Edmondson grading system, which is widely used for histologic tumor differentiation of HCC. So it all gives you so much information and pathways and guidelines and the ability. So you can break it up. For example, here, this is a stage 1A. It will go through that. It will then show you what a typical stage B looks like as well. And then, for example, stage 2, which is a T2 with no lymph node involvement or metastasis, it can show you that there's multiple lesions here, which are measuring less than 5 centimeters. Again, if I look at stage 4B, which is a T2, N1 for lymph nodes, and of course there is metastasis, and you can actually see the metastasis there in the pelvis, and you can actually see lymphadenopathy as well. So again, you can go through all of this information. You can look at the imaging findings. You can look at HCC with ultrasound, and everything is in a one-stop shop place for you to look at. And also you can go through and look at staging systems. Look at the CLIP system, the BCLC staging. You can have the child PLAS score, okay, which is really important for performance when you're staging HCC. At stage 5, that means they're dead. Stage 4 means they actually need 24-hour supervision. So then again, this helps both the non-expert in HCC versus the expert to have this information. And also when you're looking at the different classes, what are the survival rates? For a class C, you're looking at a 1 year 45% survival rate. And when you go to the second year, it's 35%. And so forth. And there's so much more. You can go to cancer history, treatment options, medical therapies, which we talked about before. Okay. And then again, you can keep going. So for example, we can look at this case here in 2017, from diagnosis to treatment of HCC, an epidemic problem for both developed and developing world. I can click onto this and it'll take me directly to the journal article of interest. And so from here, you can actually see the whole paper. This is PubMed related. This is actually, peer reviewed. It's actually published in World Gastroenterology. And again, there is also associated figures and images as well with this. And this is your typical research paper. So there is so much information that you have access to. And also you can click on here, which actually tells you, it can summarize everything in a table. So you have definitions of the tumor. You can have the lymph node characterization, metastasis, the AGC prognostic score, histologic grade, summary of changes, and metastasis. So you can also have this table here as well. But one more item I want to show you, which is of utmost importance, is when we look at cancer staging. What's important here, if you look down here at the bottom right-hand corner, we have here calculators and tables. So we can actually look at different types of calculations to different types of lesions. And more importantly, you have lung cancer, pneumothorax, and so forth. And if I click on Rad Tools, I can then go to tables. I can go to gastrointestinal. And again, look at this here. I can go to extra hepatic bile duct variants or segmental CT or hepatic segments. So if I go to hepatic segments, I can go through and look at this here. And remember, more importantly, it is not just about how you're using for diagnosis, it also has a large anatomical tool. So if we go back to gastrointestinal, I can click on anatomy. I can go look at hepatobiliary and pancreas. Again, here I can look at the liver. And again, it can show me all the anatomy of the liver, radiological, vascular, conventional angiography, and I can go down. It gives me so much information just to brush up on liver skills. But now one more thing I want to show you before I complete my lecture with you. If I click here, under every single pathology or anatomy that you go through, for example, it will tell you everything about this author. So this is Michael Federell, which is a world expert in abdominal imaging. He's a professor of radiology at Stanford University and associate chair for education for the department. And so here it tells you everything about your author. It tells you about his affiliations. More importantly, this is the second author, which is Siva Raman, assistant professor at Johns Hopkins in the US. So whoever has given information to this has really, we know who the author is as well. If I want to go back and look at the biliary system, again, it can show me the images, the schematic diagrams. It also shows me variants, and it can show me with or without them, which is quite nice. Also, it shows me the body and the neck, how they adhere to the aberrant bile duct of Luschka, which is very common, or you could have inflamed Rokitansky or the Ashkoff sinus. And so it shows you all these different types of pathologies. And it shows you under T2 MRCPs, what they look like, under ultrasound, and so forth. So these are really important clinical tools that they can use to help us, and also gives us sometimes to refresh. So everything is under one-stop shop, and it's just all 1 or 2 clicks that takes you to where you want to get to. So I'd like to conclude in thanking Dr. Ko for introducing me. I know Taiwan very well. I have some amazing friends throughout Taiwan. You are all producing such amazing work, as well as the rest of Asia Pacific. And it's been my absolute pleasure. And I'd like to thank Elsevier for allowing me to present my view on StatDX and the beauty of such an amazing product, where it's helped me and my colleagues for the last decade. Thank you very much.
Okay, thank you. Thank you, Dr. For sharing us this talk regarding the beautiful information in this system. A lot of images, including the cartoon and radiology images, has been in this system. I think probably every radiologist, not only the beginner, but also the subspecialist, can benefit from this system very well. Is there any question for Professor Charbel, Sadde? If no, I have one question.
Yes.
Do you know how often that the Elsevier updates the information? For example, the HCC and LIRAD, because a lot of our guideline is updated. Sometimes they are very often to be updated, such as LIRAD has been updated to 2018 version. So how often the StatDX update their information?
Yeah, excellent question, Dr. Ko, because again, they update it very, very frequently. So once it comes out, and there's 1 or 2 papers that are published with strong evidence, and usually with the updated guidelines, they are from strong evidence, they will roll that out, very, very quickly. But more importantly, when we look at HCC treatment in Asia Pacific, there is such a wide variety of how treatment is carried out. So you have the BCLC staging. You have in Taiwan, you guys go to resection. ESMO 2020 in March, they released it and they said, you know what, now you can use CTACE. It's better than radiofrequency ablation because of the heat sink effect, and we're not getting good results compared. But again, in Taiwan, people love to use radiofrequency as they would in China and anywhere else in the world. So with LIRADs, definitely it's within a month, it's updated very quickly on the system. And as I showed you before on the side panel, the update is happening continuously all the time. And when you have the pandemic, which we had for the coronavirus, when it started to hit the world properly in March, this is when within a month, it was out and we had imaging features, characterizations, and so forth. So they're a very moralistically company that really believes in being a tool and a support tool network for radiologists. And it's happened with me over the last decade. So I can wholly say that this is a really great opportunity to help me, because we're doing too much. We're learning so much, and so much stuff is now coming at us, and there's so much distractions, and you need this tool. So thank you so much for that question.
Excellent. I think Professor Sadde has really convinced many of us that the system is very useful. And actually, in my institute, we use this system quite often. Not only the medical students, but also the young radiologists and also senior radiologists using this system to help to learn and to practice about their daily works.
Exactly. And what's really good, I've traveled the world and I see people getting onto websites, but when I see people using StatDX, you know that this is solid quality information that's peer reviewed. Now, when you're looking at other websites, you kind of tend to worry a little bit.
Yeah, it's true. So is there any question from the audience? I don't see too many questions. So if no further question, we'll probably have to close this section. And thank you very much again for Professor Charbel today. And I hope hopefully everyone enjoyed this talk. Thank you very much.
Thank you very much, everybody. Thank you to Elsevier.
Thank you. Yeah, thank you, you too. Bye-bye.
Bye.